Good morning everyone. Myself Dr. Shania Gupta. I welcome you all. Thank you for joining us today. We are very excited to have you on today's CMA. I would like to invite our chief guest. Welcome our chief guest, Sri Sasank Sekhar sir. He is IAS and Special Secretary at Bihar Swasthya Suraksha Samiti, Government of Bihar. President of Patna Ophthalogical Society, Dr. Ajay Sinha sir. Our Secretary, Dr. Professor Gyan Bhaskar sir. Our President, Dr. Abhishek Kedia sir. Director of our institute, Dr. Ajit Kumar Devidi sir. Welcome sir. Pranav Ranjan sir and Dr. Sunil Kumar sir. Thank you sir. Now I would like to invite Dr. Shruti Priya ma'am for bouquet and shawl presentation. Sir Rakesh Kumar Singh, he is in Nanoscience and Nanotechnology Department, Aryabhatta Knowledge University, Bihar. For bouquet and shawl presentation to our respective dignitaries. To our special guest, Professor Rakesh Kumar Singh sir. Dr. Meena ma'am. Thank you ma'am. Thank you, ma'am.
So welcome and good morning to everyone. And actually, I am very thankful to IS Sri Sasank Sekhar sir for his auspicious occasion and with precious time. So I will invite Dr. Shruti Priya to give him a bouquet with and a flower. Please come forward. Please come forward and welcome him with a plant and a shawl. Bouquet. So, thank you, sir, for your gracious presence. And I will like to acknowledge our special guest, Professor Rakesh Kumar Singh, and he is a professor in Nanoscience and Technology, Nanotechnology Department, Aryabhatta Knowledge University. He has more than 75 citations from different countries. There are 75 different countries. He has the citations, more than 150 publications, and I think he has done the 7th nanotechnology lab placed in Bihar. I think it's one of its kind. We have visited here the electron microscope. He has so many things, and it's a pleasure and pride to visit that place. So welcome, sir. And I will ask Dr. Shruti Priya, please come forward to welcome him with a plant, bouquet, and bring him on a dais. And a shawl. And bring him to the dais. Please come, sir. And now I will welcome President Patna Ophthalogical Society, Dr. Professor Ajay Kumar Sinha, and he is also in PMC in Patna Medical College Hospital. He was very busy today, and he told me that I will come because he is the host, and we really appreciate the whole gesture. Please come forward, Dr. Shruti, to welcome him. The bouquet. and shawl. Now I am inviting Professor Dr. Gyan Bhaskar sir, secretary, very dynamic secretary for Patna Ophthalogical Society, also taking care of as a chairman scientific committee Bihar Ophthalogical Society, and he is so committed and desperate that the whole team runs behind him. So welcome you for your gracious presence. I acknowledge the gracious presence of our treasurer, Dr. Abhishek Kedia, and his support is immense in Patna Ophthalogical Society development, and with regular CMEs and having so many guests coming every month to Patna and visiting us, it's a pride for us. Okay. So please welcome him, Mr. I also appreciate the gesture from the Director Operations from the Ayushman Bharat, Dr. Alok Ranjan ji, and I will come forward, Dr. Shruti Diya, to give a bouquet to sir. And it's really heartfelt to receive Dr. Sanjeev, Dr. Pranav Ranjan sir and Dr. Sunil Singh sir to grace the occasion. And
Sunil Singh is the Vice President of Patna.
yes, sir. And
वो सबसे नीचे BP हो चुका है। मैं उनको BP पद कहाँ से प्रेसिडेंट के बाद BP हो गया जी? कौन सिखाएगा?
sorry sir. And sir support is immense and he always supporting, and whatever the endeavors we plan, sir is always supportive. He takes care of so many things and encourages us at each and every moment. So thank you sir. Please give a plant to sir.
शिल्पी अभी आ जाए प्लान दीजिए। फोटो रुकिए आलोक, शिल्पी आ जाए। हम नहीं आए, आप सर नहीं कर सर आइए सर एकदम से आप पकड़ सकते हैं। 5 साल के बाद सबका जरूरत पड़ेगा।
So moving forward and to welcome Dr. Pranav Ranjan sir with a plant. Sir is a guardian to us, and I will invite all guests to come forward for the lighting of lamp to inaugurate the program. Please come forward. Stand up. and they are contributing a lot to the organization because we have a lack of manpower. So Siva Bharti, please come forward for a welcome song.
आपके स्वागत में हृदय हमारा खिला, आपके स्वागत में हृदय हमारा खिला। सेवा का मौका हमको प्रभु की कृपा से मिला, आपके स्वागत आपके स्वागत में हृदय हमारा खिला। फूलों की लेके अंजलि, भावों की भाषा मछली, माथा इधर झुकाते हैं, पलके उधर बिछाते हैं, माथा इधर झुकाते हैं, पलके उधर बिछाते हैं। मुस्का रही कलियां है, रहे फूल खिलखिला, आपके स्वागत में हृदय हमारा खिला। छोटा सा है ये प्रांगण, आपके चरण पड़े पावन, छोटा सा है ये प्रांगण, आपके चरण पड़े पावन। आसन को स्वीकार करें, हम सब पर उपकार करें, आसन को स्वीकार करें, हम सब पर उपकार करें, आपके स्वागत में हृदय हमारा खिला। सेवा का मौका हमको प्रभु की कृपा से मिला।
So actually it's really a pleasure, and I just want to welcome once again for all our dignitaries coming here, and just wanted to highlight few things in 2 words that Rajendra Super Specialty Ophthalmic Science Center is a visionary institute which was initiated in 2013. Basically came in force in 2021, I think, with a new building. And in last 3 years, it has grown from 15,000 per year OPD to 66,000 per year OPD in last year. And this year, up to October, it has 44,000 OPD in the already done. In total 6 months. Total 6 months, it has a 44,000, which is already more than what we are achieving because the busy season is upcoming here. And surgical wise as well, last year there was 2,900 surgeries were performed here, including FACO and other specialties. And this year already we have achieved 2,400 surgeries up to October only. So I can say at this moment that we have the potential to become a world-class center at a good institute and a good high hospital. So this is the fact, and our academic activities continues by month, I will say twice in a month, and with the ophthalmic intern training themselves for them, other student junior colleagues, as well as the senior doctors are working behind to take care of everything. So we salute our peers, and I will ask the government of India is there for the further support to this organization. So with this note, I will ask our president, Dr. Ajay Sinha sir, to say a few words. Actually, it's our pleasure to host the post CME, which is a regular monthly affair here. Please.
Honorable Chief Guest, Shri Shashank Sekhar Sir, Special Guest, Professor Rakesh Kumar Singh Sir, and other distinguished guests on and off the dais. पॉस के प्रेसिडेंट का पोस्ट संभालते वक्त मैंने अपने प्रेसिडेंशियल स्पीच में भी कहा था कि वन ऑफ माय टॉप प्रायोरिटीज एज प्रेसिडेंट will be to create an environment of collaboration and knowledge sharing among our members, whether it's through CMEs, research initiatives, or professional development opportunities. इसी कड़ी में एक प्रयास हम आज भी कर रहे हैं और मेरा मानना है कि we must continuously strive to push the boundaries of what is possible in eye care. और excellence हमारा गोल नहीं, हमारा स्टैंडर्ड होना चाहिए. That we all should try to maintain in everything or anything we do. हर वो मरीज जो आपके क्लिनिक या हॉस्पिटल के दरवाजे से अंदर आता है, he deserves nothing less than the highest quality of care, delivered with compassion and empathy. This is what we are trying to do. Thank you, sir. Thank you.
Thank you, sir, and we will try to push your vision forward. Now I invite Vice President 2, Dr. Sunil Singh sir, to come forward and say few words, sir. And he is a blessing for us and always guides us in our endeavors.
अरे यार अजीत, तुम फिर वन को टू कर दिए, भूलिए जाते हो, क्या कर रहे हो, हमको तो दुश्मनी निकाल रहे हो क्या? रिस्पेक्टेड शशांक शेखर सर, राकेश सर और हमारे छोटे भाई, हमारे कलीग अजय, प्रेसिडेंट, आशीष, ज्ञान भास्कर सर, प्रणव सर, हमारे सीनियर मोस्ट यहाँ पे सब लोग यहाँ पर आलोक हैं. एंड रियली राजेंद्र आई हॉस्पिटल को देख के मुझे लगा कि स्वास्थ्य मंत्री मंगल पांडे जी, शशांक शेखर जी, प्रत्यय अमृत जी ने क्या बिहार को एक गिफ्ट दिया है. और उसके साथ इस कड़ी में आयुष्मान भारत का जुटना एक अलग कीर्तिमान है, एक माइलस्टोन है, क्योंकि गरीबों की भी सेवा होनी है. और जिस देख सकते मैं तो उसका BP1 हूँ, लेकिन यहाँ पे नहीं आया था. मैं मानता हूँ कि हमारी नॉलेज कम था और देख के हमें लग गया कि टोटल कंप्लीट ऑप्थेल्मिक सेटअप, जिसमें कि सुपर स्पेशलिटी भी है, गरीबों के लिए आयुष्मान भारत भी है, और रेटिना के लिए स्पेशलिटी के लिए सिद्धार्थ ऐसे सर्जन आए हैं और रियल में सर्जन लोग आए हैं. ये निश्चित ही एक खुला एक सेमिनार हॉल, ये बड़ा ही एक बात है और हम लोग बहुत खुशी है और हम इसके लिए सरकार को धन्यवाद देते हैं और यहाँ के लोग को, डायरेक्टर को, अजीत हमारा भले नाम भूल जाए, डायरेक्टर को धन्यवाद देते हैं इतना बढ़िया से इस कीर्तिमान को स्थापित किया है. और सब लोग जो अच्छे अच्छे फैकल्टी आए हैं, उसके लिए बहुत ही आपको साधुवाद है और बहुत बड़ी अच्छा बात है. और मेरा नाम भूलने का कारण मैं खुद हूँ. पिछले 2 पॉस CME में मैं खुद नहीं आया था. नहीं आइएगा, लोग भूल जाएंगे. ये एक लेसन है. आप लोग भी जुड़े रहिए, आते रहिए, ज्ञान का आदान प्रदान करिए, सभी लोग याद रखेंगे. एंड फिर से धन्यवाद आप सब ऑर्गेनाइजर को, बड़े हॉस्पिटल के डायरेक्टर को और बॉस को जो रेगुलरली CME करता रहता है. और अजय ने कहा कि उसको इंटरैक्टिव और कोलैबोरेटिव बनाना है. कोलैबोरेशन के क्रम में अजय बता दें, ये जैसे शशांक सर बता रहे थे, ये कोलैबोरेशन हो रहा है संकट नेत्रालय से. तो आपके जो कोलैबोरेटिव चीज़ का जो था, तो इसका कोलैबोरेशन संकट नेत्रालय से हो रहा है. इसे शशांक सर बताएंगे, तो भी याद रखना होगा. धन्यवाद.
Thank you, sir. Now I will ask for specialty book release. So we have a specialty OPD and which documents everything, and that was made in a way that can be propagated and recorded by the patients who don't get every time in a queue to from the OPD, and so they will come directly to the specialty clinic. So they are get enrolled. Once enrolled, they can come directly to the specialty clinic. So that the previous doctors did not need to search here and there. So please bring those booklets, and I will invite Professor Rakesh Kumar Singh to release this book and along with the whole dice. Please. It's a small booklet because we as a doctor, we feel that whenever we do a lot of work, especially in ophthalmology, we need to document. And so that the next time that record is available for the patients as well as to us, so it will help us.
Ma'am, please.
Okay, TV Chaudhary, sir. Dr. TV Chaudhary sir is the oldest association with this institution and is the pillar of the institution as a guardian to us as well. So it's necessary information for the patient as well as the whole, it contains 16 booklets at least inside that. Thank you. And now I will invite Professor Rakesh Kumar Singh to say a few words. And Sunil Singh sir was talking about collaboration, and nanotechnology is the upcoming field, I think. Even in glaucoma, this workshop is on a glaucoma CME and workshop. So the upcoming area is of the nanomers, lysosomes, and so many drug delivery devices. And definitely the nanotechnology is going to help. And I remember, sir, when I was presenting in GSI Guwahati, and that was the sustained release devices in glaucoma and drug delivery systems in glaucoma. And sir has a lot of articles on that. When he had a research in the whole booklet, he provided a thesis to me. And it's really, so we want to collaborate with Albert Knowledge University too, along with Centra, so that we can come forward. Please, Professor.
Thank you, the Chief Guest of this program, Sri Shashank Sekhar sir, the IES and the Special Secretary, Bihar Swasthya Suraksha Samiti, Government of Bihar. Sri Dr. Sunil Kumar Singh sir. Sir, I have been very known figure. I joined as a lecturer in Patna Women's College from 2004. A very known figure was the President Professor Ajay Sinha sir, Dr. Gyan Bhaskar sir, Abhishek Gadiyal, and Dr. Ajit Kumar Bedi sir, the director of this hospital, and Dr. Meena Menon, the other guests, the faculty members and the staff members. सर ने 2 मिनट समय दिया है मुझे, और मैं नैनो टेक्नोलॉजी का स्पेशलाइजेशन के एरिया में काम करता हूँ। कम समय में मैं इतना ही कह सकता हूँ कि पूरी जो हेल्थ सिस्टम है, पूरी जो बायोलॉजिकल सिस्टम है, पूरे जो फिजिकल वर्ल्ड है, ये पूरे सूक्ष्म लेवल पर ऑपरेट होता है। उस सूक्ष्म लेवल को हम लोग नैनो स्केल कहते हैं। उस नैनो स्केल का साइज 10⁻⁹ मीटर होता है, जिसको हम खुली आंखों से नहीं देख सकते। उसको एक इलेक्ट्रॉन माइक्रोस्कोप से देख सकते हैं। हमारी लेबोरेटरी में अल्बर्ट नॉलेज यूनिवर्सिटी में 3 इलेक्ट्रॉन माइक्रोस्कोप हैं। आप आके कभी विजिट कर सकते हैं, अभी सर आए हैं। और नैनो मेडिसिन के फील्ड में हम लोग बहुत विस्तार के रूप में काम किया है और कर भी रहा है। खास करके बिहार को परिदृश्य को देखते हुए कि बिहार की जो लोकल रिसोर्सेज हैं, इस पर आधारित कैसे रिसर्च को हम बढ़ा सकते हैं। माननीय मुख्यमंत्री जी को मैंने करीब 2010 के करीब में मैंने एक प्रपोजल दिया था नीतीश कुमार जी को, और हमारे प्रपोजल को उन्होंने बहुत अच्छे से स्वीकार किया और एक वर्ल्ड क्लास नैनो टेक्नोलॉजी रिसर्च सेंटर की स्थापना हम लोगों ने अल्बर्ट नॉलेज यूनिवर्सिटी में माननीय मुख्यमंत्री जी के सहयोग से शुरू किया। अभी जैसे सर ने कहा, करीब हम लोगों ने 200 इंटरनेशनल रिसर्च पब्लिकेशंस किया है और नैनो मेडिसिन के फील्ड में करीब 50 से ज़्यादा हम लोगों ने अच्छे काम से किए कि नैनो मेडिसिन में हम लोग बेसिकली करते क्या है, जितने भी मेडिसिन हैं जनरली वो नैनो होते हैं, लेकिन उसकी इफिकेसी को हम छोटा स्केल पे ले जाके उसको बढ़ाना, उसके साइड इफेक्ट पर स्टडी करना, उसके डिलीवरी पर स्टडी करना, उसके मैकेनिज्म को देखना, ये सारे काम हम लोग बिहार में रह के कर रहे हैं। कुछ अन्य जगहों से मिलकर भी हम लोग कोलैबोरेट कर रहे हैं। तो कम समय कम है, लेकिन इसके प्रिपरेशन, इफिकेसी, मैकेनिज्म, डिलीवरी, एक्शन और साइड इफेक्ट, ये सारी चीज़ों को हम लोग देखने की कोशिश करते हैं। बैकग्राउंड मेरा फिजिक्स रहा है, लेकिन हम लोग इस एरिया में नैनो मेडिसिन में सबसे ज़्यादा काम कर रहे हैं इंटरडिसिप्लिनरी एरिया होने के नाते। और बिहार में हम शोध के क्षेत्र में, मेडिसिन के फील्ड में, हेल्थ के फील्ड में अपने रिसोर्सेज पर आधारित काम को कैसे बढ़ा सकते हैं, इसको देखते हुए हम लोग काम करते हैं। जैसे एक छोटा सा एग्जाम्पल सभी मैं ले रहा हूँ, टर्मरिक को सब लोग हम लोग खाते हैं, लेकिन वो टर्मरिक क्यों खाते हैं, उसके हल्दी पाउडर, कर्क्यूमिन हम लोग बोलते हैं कि उसकी इफिकेसी ज़्यादा होती है। आखिर इफिकेसी क्यों ज़्यादा होती है या साइड इफेक्ट कम क्यों होता है? तो साइड इफेक्ट कम होने के कारण होते हैं, जब इलेक्ट्रॉन माइक्रोस्कोप से उसकी इमेज को देखते हैं तो उसके इमेज माइक्रोस्ट्रक्चर होते हैं, यूनिफॉर्म माइक्रोस्ट्रक्चर इमेज होती है। तो आपका ट्रीटमेंट और हमारा रिसर्च, हम दोनों को जोड़ते हैं और उसके आधार पर हम लोग रिसर्च पब्लिकेशन करते हैं। अजीत सर ने बहुत सारी चीज़ों को आगे देखा भी है, तो इस तरह की चीज़ों को हम लोग करते हैं। आप लेबोरेटरी आ सकते हैं, हम लोग का देख सकते हैं किस तरह के काम करते हैं। IGMS के डायरेक्टर सर ने भी आया था, अभी हम लोग वहाँ से भी हम लोग MOU कर रहे हैं। सुनील सर को जब मैं बहुत यंग लेक्चरर के रूप में ज्वाइन किया था पटना विमेंस कॉलेज में 2004 में, उस समय से हम लोग आपको सर जानते रहे हैं। चिकित्सा क्षेत्र में आप काफ़ी अच्छा काम किया है, राजनीतिक क्षेत्र में भी, सामाजिक क्षेत्र में भी आपको टेलीविजन पर हम लोग देखते रहे हैं, है ना। सारे चिकित्सक लोग हैं या फैकल्टी लोग हैं, स्टूडेंट्स हैं, एक बार लेबोरेटरी में विजिट करें। हम लोग के काम को देखने के लिए कोई जरूरत नहीं, गूगल स्कॉलर में आप डालेंगे नैनो मेडिसिन डॉक्टर राकेश कुमार सिंह पटना, तो बहुत सारे काम दिख जाएंगे, उस काम को आप देख सकते हैं। और कैसे इस माहौल में हम लोग रह के बिहार में एक MOU करके, कोलैबोरेशन करके, इंटरेक्शन करके बिहार राज्य की गरिमा को अंतर्राष्ट्रीय मंच पर लाके हम लोग दिखा सके, एक बहुत बड़ी हम लोगों का दायित्व भी है। किसी ने कहा था, इस देश को रखना मेरे बच्चों संभाल के। तो हम लोग जब भी बाहर जाते हैं तो कहा जाता है बिहार में मेडिकल साइंस की चर्चा होती है, हेल्थ साइंस की चर्चा होती है, रिसर्च की चर्चा होती है। तो रिसर्च के क्षेत्र में, इनोवेशन के क्षेत्र में, हेल्थ और मेडिसिन के क्षेत्र में हम लोग रह के बहुत अच्छे काम कर रहे हैं। जो भी हम लोग की समस्याएं हैं, हम लोग का माहौल है, और इसी में रह के एक साथ मिलकर हम लोग अच्छा कर सकते हैं। जहाँ पर इंजीनियर्स हो, डॉक्टर्स हो, प्रैक्टिशनर्स हो, साइंटिस्ट हो, सबके कन्वर्जेंस के, सबके साथ मिलके एक अच्छा माहौल हम लोगों ने बनाने की कोशिश किया है और आपके साथ मिलकर और अच्छे काम भविष्य में करेंगे। इसी शब्दों के साथ मैं अपनी वाणी को विराम देता हूं।
निश्चित रूप से सर, बिहार को बहुत ज़रूरत है। हम समझते हैं हमारे जो क्वालिटी है, हमारे जो क्वालिटी सर्जन्स हैं, बहुत सारे लोग हैं, दे आर वर्किंग एंड दे वांट टू कोलैबोरेट विद यू, चीज़ें और भी अच्छे तरीके से सोशल फ्रंट पे आए। और मैं अपने गेस्ट स्पीकर को के बारे में बता दूं। ये उनका यहाँ होना ही बहुत बड़ी बात है और उन्होंने मुझे एक because he is the mentor of many of the ophthalmologists here. Dr. Deepak Agarwal sir was saying, Dr. Silpi Kedia was saying, I am also from Darwin in 2009 and ma'am was there and mentoring many students there. And ma'am has done the efforts here in 2001 and practicing in Central Netra Shankar Eye Hospital since 2007 itself. To which sir we are collaborating. So she is there as a consultant in glaucoma consultant. And I will like to ask her to come forward to receive the memento from the Special Secretary Sir, Sri Sasank Sekhar Sir. You have come to the Bihar for the first time, I think. So you must be, please come forward. Please come forward. Please come forward. Micro-incision glaucoma surgery is also, I can say, nanotechnology is 10.9, micro-incision 10.6. So we are also, it's a live demonstration and workshop will be here. And now I will invite our Special Secretary Sir to say a few words, because this institution, this organization needs a lot of support from Bihar government. Government is already working upfront for this institution, and I have a lot of expectations and effort from the department of this. Please, sir. Please, thank you.
थैंक यू डॉक्टर अजीत जी। सबसे पहले मैं थैंक्स बोलूँगा डॉक्टर अजय कुमार द्विवेदी जी, उन्होंने आज इस प्रोग्राम में मुझे इनवाइट किया CME में। ओरिजिनल प्रोग्राम तो हम लोग का आयुष्मान भारत के काउंटर का उद्घाटन था। तो ये जो है पटना ऑप्थेल्मोलॉजिकल सोसाइटी के अध्यक्ष डॉक्टर अजय सिन्हा जी, वाइस प्रेसिडेंट डॉक्टर सुनील कुमार सिंह जी, जो हमारे स्पेशल गेस्ट हैं प्रोफेसर राकेश कुमार सिंह, नैनो साइंसेज एंड नैनो टेक्नोलॉजी डिपार्टमेंट, आर्यभट्ट यूनिवर्सिटी के, आज पहली बार मुलाकात हो रही है। सेक्रेटरी डॉक्टर ज्ञान भास्कर जी, ट्रेजरर अभिषेक केडिया जी, यहाँ उपस्थित जो वरीय नेत्र चिकित्सक जिन्हें मैं पहले से जानता हूँ, डॉक्टर प्रणव रंजन जी, डॉक्टर मीना मेनन जी, श्री आलोक जी आयुष्मान भारत से। ये आज का दिन बहुत ही अच्छा है हम लोग के लिए कि आज से करीब 1 महीना 1.5 महीना पहले पता चला कि राजधानी नगर आज हॉस्पिटल में अभी तक आयुष्मान भारत की सुविधा नहीं है। हम डायरेक्टर साहब को थैंक्स बोलेंगे कि इन्होंने बहुत ही अपनी ओर से प्रॉम्प्ट रिस्पॉन्स, गवर्नमेंट ने भी प्रॉम्प्ट रिस्पॉन्स दिया कि 1 महीने के अंदर आज ये काउंटर कार्यरत है। सबसे ज़्यादा आयुष्मान भारत के जो क्लेम्स है वो भी आई से ही आते हैं। तो मुझे पूरा उम्मीद है कि यहाँ पर जो पेशेंट्स आएंगे उनको काफ़ी ज़्यादा फायदा होगा। पता नहीं आयुष्मान भारत हम देखें कि जो भी मतलब मैक्सिमम जो हम लोग रीइंबर्स करते हैं वो हम लोग आई से ही कर रहे हैं। और इसमें थोड़ा डिक्लेरेशन में गड़बड़ी है। मैं चीफ एग्जीक्यूटिव अफसर हूँ बिहार स्वास्थ्य सुरक्षा समिति का। ये हॉस्पिटल हमको याद है 2000 माननीय मंत्री श्री मंगल पांडे जी बने थे, 6 महीने के बाद हम लोग इस हॉस्पिटल में उनके साथ आए थे। पुराना बिल्डिंग था, बहुत ही टूटा फूटा बाथरूम। ये वो उस वक्त के डायरेक्टर सरिया सर जी थे। तो माननीय मंत्री जी ने बहुत निराशा व्यक्त की थी कि इस अस्पताल का ये स्थिति है, जर्जर स्थिति है। उन्होंने उस दिन ये संकल्प लिया था कि मैं इस हॉस्पिटल को रिनोवेट कराऊंगा। इसमें कई समस्याएं आई। पूरे देश भर के जो महत्वपूर्ण कंसल्टेंट्स हैं उनको बुलाया गया इसका डिजाइन करने के लिए। ये पूरी तरह से स्टेट फंडेड स्कीम है, इसमें कोई भी सेंट्रल गवर्नमेंट ऑफ इंडिया का पैसा नहीं लगा है। लेकिन हमारे माननीय मंत्री जी का पूरा कन्विक्शन था कि इस हॉस्पिटल को हमको अच्छा बनाना है। और आज हम आए, उसको देख के बहुत मन खुश हुआ। और इतने सारे ओपीडी में पेशेंट्स को देख कर और भी लगा कि चलिए जो उनका ड्रीम था वो पूरा हुआ। तो सरकारी इस हॉस्पिटल बीच में फिर पता चला कि यहाँ डॉक्टर्स नहीं है। हम लोगों ने अच्छी संख्या में जो भी पॉसिबिलिटीज थी हम लोगों ने यहाँ डॉक्टर्स को भी पोस्ट किया। जैसे इसके चलते अभी पता चला कि सारे सुपर स्पेशलिटी के भी डॉक्टर्स आ गए हैं। तो ये और भी अच्छी बात है। ये हॉस्पिटल बहुत ही अच्छा करे। अभी एक जो डॉक्टर सुनील और लोगों ने कहा, तो अभी कुछ इसका भी और भी डेवलपमेंट अभी है, लेकिन पाइपलाइन में अभी बोलना ठीक नहीं है, लेकिन वो पाइपलाइन में है। मुझे लगता है कि ये कुछ दिनों में ये बिहार का सबसे प्राइम सेंटर होगा आई के क्षेत्र में। एक और राज्य सरकार का भी हाल में ही माननीय केंद्रीय स्वास्थ्य मंत्री जी ने उद्घाटन किया RIO का, वो भी इसी ढंग का बहुत ही बड़ा स्ट्रक्चर है। पहले पटना में आई हॉस्पिटल का मतलब 2-4 कमरे का एक हॉस्पिटल हुआ करता था, उससे काफी चेंज आया है। यहाँ बड़ी संख्या में यहाँ कई तरह के रिसोर्सेज का प्रॉब्लम है। द्विवेदी जी या जो भी डायरेक्टर थे जब भी कहे, सरकार ने पूरी वो सपोर्ट किया है और आज उसका रिजल्ट देखने को मिल रहा है। और आज इस कार्यक्रम बेसिकली जो हम लोग बोल रहे हैं पटना ऑप्थेल्मोलॉजिकल सोसाइटी का वर्कशॉप है, टेक्निकल सेशन है, और हम लोग को लगता है कि इसमें आज जो आप लोगों का जो चर्चा होगा इससे काफ़ी फायदा होगा। हमारे कई स्टूडेंट्स दिख रहे हैं यहाँ, PG बॉन्ड वाले भी काफ़ी डॉक्टर्स हैं हमको लगता है, तो वे सभी लोग इसका जो है सो फायदा उठाएं। और वंस अगेन डॉक्टर द्विवेदी को धन्यवाद, इन्होंने इतना अच्छा कार्यक्रम आयोजित किया। थैंक यू।
Now, thank you, sir, and we are looking forward, and definitely we will get more support, and as you have promised. Now I will invite Professor Gyan Bhaskar, sir, our Secretary, Patna Ophthalogical Society, to give a vote of thanks, and he will also elaborate about this upcoming CME, and then we will start the session.
Thank you, Divyaji. First of all, I would like to welcome you all on behalf of Patna Ophthalogical Society and Scientific Committee for today's CME and some inaugural functions. First of all, I would like to thank and welcome Ma'am Dr. Meena Menon for today's giving her time for today's very special CME का WhatsApp on the ग्लूकोमा। हम लोग समझते हैं कि ग्लूकोमा में सिर्फ 4 या 5 दवाइयाँ जिसे लिखनी है बस, लेकिन वो 4-5 दवाइयाँ लिखने के लिए करोड़ों का इन्वेस्ट करना पड़ता है और मरीज को शायद महीनों या सालों डॉक्टर के पास जाना पड़ता है। तो आज हम समझते हैं कि डॉक्टर मीना मीना जी और हमारे जो जितने भी अदर जो एक्सपर्ट्स हैं, वो हमारे जो लीवर कलीग हैं, जो PG स्टूडेंट हैं, उनको कुछ एक ऐसा टिप्स आज देंगे जिनसे लगेगा कि अगर हमें कोई एक दवा लिखनी है या नहीं लिखनी है, या लिखनी है तो कब लिखनी है। तो आपको मैं वंस अगेन वेलकम एंड थैंक्स कि आपने समय दिया, और हम समझते हैं कि हम सभी उसका लाभ उठाएंगे, और आने वाले समय में हमारे साथ साथ हमारे जो बिहार के जो मरीज यहाँ विशिष्ट जो नेत्र विज्ञान है राजेंद्र नगर, उसमें जो आते हैं उनको डेफिनेटली लाभ मिलेगा। और मैं पूरी टीम जो यहाँ काम कर रही है, डॉक्टर अजीत कुमार द्विवेदी, डॉक्टर CB चौधरी और जितने भी लोग हैं जो यहाँ काम कर रहे हैं, उनको धन्यवाद कि उन लोगों ने आज आलोक से आज उद्घाटन कराया आयुष्मान भारत का, जो कि एक मेडिकल ट्रीटमेंट इतना महंगा है कि बिना आयुष्मान भारत या बिना सरकार के सपोर्ट का शायद इलाज संभव नहीं है। तो आप सभी को धन्यवाद सर, और स्पेशल थैंक्स राजेंद्र हॉस्पिटल की तरफ से और पटना ओप्थेलोजिकल सोसाइटी की तरफ से श्री शशांक श्रीधर सर को धन्यवाद देना चाहते हैं सर, जो अपना व्यस्त समय में टाइम निकाला। सर के पास हम लोग तो कभी कभी आइटम्स के काम को लेकर के सचिवालय में जाते रहते थे, तो सर इतना व्यस्त रहते हैं कि फुर्सत ही नहीं। सर वेलकम सर, थैंक सर, आपने समय निकाला, और हम समझते हैं कि आपके सहयोग से सर राजेंद्र नगर के विशिष्ट नेत्रालय डेफिनेटली आने समय में सर और अच्छा करेगा। थैंक्स टू प्रोफेसर राकेश कुमार सिंह सर, आप अपना समय निकाला सर, आपके लिए आपको सर बहुत बहुत धन्यवाद। और स्पेशल थैंक्स टू सुनील सर, प्रणव सर, हमारे प्रेसिडेंट अजय सर। सबसे दिक्कत होता है सर अभी के समय में कि हम लोग को अगर हॉस्पिटल में मरीज को छोड़ के यहाँ इस समय रहना अपने आप में थोड़ा कष्टदायक है। तो सर थैंक्स कि आपने सर समय निकाला। हमारे ट्रेजरर साहब डॉक्टर अभिषेक केलिया, इनके बिना सहयोग के सर कोई भी प्रोग्राम संभव नहीं हो सकता है। और मैं बहुत समय नहीं लूँगा, थैंक्स बोलना चाहता हूँ डॉक्टर शिल्पी, डॉक्टर गौतम जो यहाँ पे पहले थे और इन्होंने शायद सरकार इन्हें ग्लूकोमा के लिए स्पेशली एम्स में ट्रेनिंग के लिए भेजा था। और एवरीवन को बहुत बहुत धन्यवाद। और सारे जो आज राम आए और अपना रजिस्ट्रेशन कराए और समय दिए। थैंक यू।
So we all will raise for the next our national anthem. जन गण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा। तब शुभ नामे जागे तब शुभ आशीष मांगे। गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे। Thank you. I will request Dr. Praveen to come forward for the CME conduct and we will meet.
So in the collaboration with Patna Ophthalogical Society and Nagar Super Specialty Eye Hospital, so there is very fantastic CME has been organized, and I think it will be very helpful for the glaucoma specialists, also for the trainees. And first presentation will be done by Dr. Shilpi ma'am, and on the gonioscopy based case discussion. As we all know, gonioscopy is one of the most clinical tool for differentiating glaucoma, for identifying, diagnosing glaucoma, and able to treat the glaucoma. So welcome Dr. Shilpi ma'am, and please come on the desk for the presentation.
Good morning all. At the outset, I would like to thank Dr. Ajit sir and Patna Ophthalogical Society for giving me this opportunity. So I'm just going to present one case. A 38-year-old female presented with severe pain, redness, nausea, decrease in vision from past 7 days. She is a known hypertensive since 1 year but on irregular medication. Other than this, she is not taking any systemic medication. On ocular examination, her best corrected visual acuity in the right eye is 6/12 partial and the left eye is 6/9 with plus 1/2 diopter spare. Conjunctiva in the right eye was circumciliary congestion, corneal edema, AC depth of one helix grade 2, pupil was 4 mm and sluggishly acting to the right light. The intraocular pressure was 68 in the right eye and the left eye the intraocular pressure was 54 mm of angle. The gonioscopy in the right eye was not very clear due to the corneal edema. The left eye revealed occludable angle which opened up with indentation. The right eye fundus was not very clear but it looked like a shallow curve with CDR of 0.9. The left eye had a similar finding. So with all this, I came to the diagnosis of right eye acute angle closure glaucoma and left eye primary angle closure glaucoma. So with this, the same setting I advise under IV Manular, I advise in both eye laser peripheral iridectomy. The laser was done successfully. So after the laser, the post laser eye drops continue and tablet Diamox BD for 7 days. She was asked to come for review after 7 days. In the first follow-up time, she came with the same complaint. Still the corneal edema was present in the right eye. Intraocular pressure in the right eye was 62 and left eye is 48. Both eye PI was fatal. The post-PI gonioscopy was not clear again due to the persistent corneal edema in the right eye. So this time also I advise IV mannitol and all other anti-glaucoma medication was continued as such. I added 2% pilocarpine 4 times a day and latanoprost for night application. Oral acetazolamide was continued. So in the third follow-up day, which is 7 days from the last review, so this time patient was feeling much better. The best corrected visual acuity in the both eyes was 6/6 partition. Cornea was relatively clear. The IOP was 28. So thinking that this patient respond well with the pilocarpine, I switch off withdraw the oral acetazolamide and added dorzolamide eye drop. The fundus showed marked reversal of crop from 0.9 to 0.75. This is an anterior segment photograph of the right and the left eye showing a patent peripheral iridectomy. This is the sled photograph of right and the left eye showing pretty good anterior chamber depth post laser. And the right angle, this is a temporal nasal angle. Nasal and temporally, scalar spur is well visualized in the gonioscopy, and in the superior and the inferior angle, trabecular meshwork is visualized with indentation. The same finding is found in the left eye also. The left eye, the temporal and the nasal angle showed scalar spur, and the superior and the inferior is the superior and the inferior angle showed the trabecular meshwork. So in the second review, the patient was much better from the last review. So I called the patient after 10 days. But patient was presented to me within 5 days with the same complaint of ocular pain, watering, blurring of vision. This time her best corrected visual acuity in the right eye reduced to 624 and the left eye is 66 partial. Cornea in the right eye again show corneal edema. The pupil was mid-dilated and sluggish reacting to light. The IOP again increased to 62 mm of Hg in the right eye and 30 mm of Hg in the left eye. This visit really alarmed me. Am I missing something or she needs some other investigation to rule out secondary cause of rise intraocular pressure? So the fundus photograph, again the cup size increased from 0.7 to 0.9 in the right eye and the left eye is around 0.7 with the developing inferior notch. The OCT showed the marked thinning of the retinal nerve fiber layer in almost more than the 3 quadrants. So what comes to my mind for the differential diagnosis of this case is that the case of nano-ophthalmos or the secondary angle closure due to any systemic drug use or having choroidal mass or suprachoroidal effusions. For this, just to rule out the nano-ophthalmos, the axial length was measured. The right eye is 22 mm of 32.29 mm of and the left eye is 22.15. With the normal RCS thickness. So nano-ophthalmos are ruled out. Ultrasound B scan in both eyes was done. There is no mass and the RCS shows the normal thickness. This is the left side USG B scan. We don't have a UVM in our setup, but we are not yet reached to any conclusive diagnosis. So we took the patient to the different center to for the UVM. UVM is not showing any ciliary body rotation, anterior rotation of ciliary body or supracorviral effusion. Just one. So this is the UVM video. There is no anterior rotation of the ciliary body, and I keep asking the patient about the use of other systemic medication. She was not agree or she is denied for the use of other systemic medication. The left thigh UVM is also not showing any rotation or supracorviral effusion or mass hemorrhage, anything. So with my best effort, I could not reach any conclusive diagnosis. But what I learned from my what I reached and by discussing with all my mentors, I explained the urgent need for the trabeculectomy with mitomycin and the IV mannitol with all intraoperative precaution, because this patient has uncontrolled IOP in every visit and the chances of expulsive is very high intraoperatively. So we already counseled the patient about the need of trabeculectomy. The precaution what is in my mind is like a pre-placed suture or guarded anterior chamber entry or the releasable suture. Now I would like to call my learned guest speaker, Meena ma'am, regarding the further what we can do best for this patient, what further management will be.
I think you have managed it very well, in the sense like you've tried ruling out all the secondary causes and for this. So we'll put it as, further management will be definitely a surgical management, because medically I think you have tried maximum medication. Now only thing is that pseudo-exfoliation is one thing. I'm sure she has ruled out.
It's not there because
yeah, no, that's what. Pseudo-exfoliation is one condition wherein you can get these kind of intractable high pressure with open angle. So that is also not there, and once it is opened, now probably there is some level of chronic angle closure, some kind of patchy PAS might be there, which would have kind of little bit got opened up.
It happens like the angles are patchy and hyperpigmented, but why I'm worried, because in all the visits she has a pressure of around 60, 58. Just one visit she has 28 IOP. That too maybe because we just started pilocarpine 4 times a day, but that also not work very long.
So I think the next level is only trabeculectomy. Now the only thing is that during trabeculectomy, as she rightly pointed out, we have to be very, very careful, because it's a high pressured eye. So you have to do it under IV mannitol. So what in my practice, I give mannitol before the surgery as well as on table during the surgery also. Second thing is extremely slow paracentesis, and definitely a pre-placed suture. You can opt for, if you don't have a suturolysis options, you can opt for a releasable suture. I am not a great fan of releasable suture, so I put only one suture for my trap, but there is nothing like I'm a great surgeon if I put one suture. You can always put 3 sutures. You have a facility for suturolysis, you can do a suturolysis at a later date. But the most important thing is make sure that you have a pre-placed suture. So the moment you enter, suture it immediately so that you don't have a sudden collapse. Now definitely next day 100% you have to dilate and see. You have to dilate and see whether there is any sudden decompression signs. decompression retinopathy is very common. So sometimes if the hemorrhage is sitting on the macula, there is a possibility that the patient's vision will drop. So you should reassure the patient that the vision will come back, because this is a sign of decompression retinopathy. We have had instances patient feels कि अभी surgery किया है, vision चला गया. So it is not like that. You have to make sure that you check the fundus for any signs of CDs. Huge CDs can be there, you have to manage immediately, or a sign of decompression retinopathy. Good case and management.
So, madam, one query for you, madam. This side.
Oh, sorry.
Yeah, this is Dr. Chuman. Yeah. I mean, for doing a trabeculectomy with high pressure, I mean, is there any higher borderline, something rough borderline which has to be defined under which we can safely do the trabeculectomy? We have to bring it down to what level?
See, we try to bring it down to as much as possible. That will be the dictum. But sometimes there are occasions like this wherein whatever you do, you cannot really bring it down. In that circumstances, we don't have a choice. Otherwise, generally 30s are some pressure. 30s is a pressure wherein you can comfortably do even without mannitol and all that. Beyond 30s, you have to make sure that an IV line is secured. So in case you have a problem, keep the mannitol ready. And in case you have a problem, you can always connect the mannitol immediately. 30 to 32, I will say it is a very comfortable pressure without mannitol. Beyond that, such circumstances, we don't have a choice. Otherwise, patients can end up.
Will it not be a good idea to keep the patient on mannitol 1 to 2 hours before surgery?
Yeah.
One evening before also give a mannitol.
Yeah, definitely that's
Check
what.
the pressure on the NCT.
Yeah,
and
definitely.
then be comfortable.
Yeah,
What
yeah.
about oral glycerol and glycerine and all?
See, the oral glycerol, such situations plus minus. Because I will prefer oral glycerol whenever you want to decrease like a vitreous volume. So in such kind of a phakic guy, it may not have too much of a effect. Now second thing is when you pump in Diamox, oral glycerol, the patient is very uncomfortable. You know, the taste of side effects of acetazolamide plus the oral glycerol. So you can try, there is no harm in giving oral glycerol.
Which is tap, if the biscuit is a good option before surgery.
So in such situations, I keep my colleagues, retinal surgeons are always there. So in an institutional practice, we are always a little on the safer side, and of course you are also on the safer side.
She has the advantage.
Yeah, that's what.
She has the advantage.
That's why I'm looking at her. So you can always keep them, but nothing really happens. I'll tell you. I mean, touch wood. Like if you are taking all these steps, it really doesn't happen. What I have seen more commonly is a decompression retinopathy.
Okay. One more thing. Is the chances of expulsive is also there most of recovery time?
Once you have entered, then the expulsive is not very common. That is why I said under IV mannitol. The moment you enter and start suturing, you switch off the IV mannitol. So you don't go in for too much of a decompression. So once you have entered, you are already done the decompression. Then you switch off the IV mannitol because in further you are reducing it.
Thank you.
I have asked my retina colleague to do a tap only if it is a viral, if I am suspecting a viral uveitis secondary glaucoma. That is a very dreaded thing, viral uveitis with secondary glaucoma. There I have asked my retina colleague to do a vitreous tap. I don't ask them to do a vitrectomy. Just keep the port, release it, that is enough.
Thank you, ma'am, and I think it's a really a good lesson to learn that even with the advanced glaucoma, especially in such time, we should not hesitate to do the surgery first, and at the same time, we should take all precautions which are required and be very particular regarding that. So thank you, Dr. Secretary, and I will like.
Thank you, Secretary ma'am and ma'am for RPD valuable input. So sometimes we have to be khatro ke khiladi. So the second case presentation will be done by Dr. Ritika ma'am, again on gonioscopy.
And there is one announcement, the people who are enrolled for the workshop. So after Dr. Minaman's talk, we will go to the second floor and we will go group wise. And the team is ready, I think, from Mr. Manu Naranga. Yes.
Good morning, everybody, and thank you, sir, for the opportunity. I'll be presenting on gonioscopy. It is just a collection of my gonio photographs. So brushing up the knowledge of gonioscopy before going for MIGS workshop is what was intended. Gonioscopy remains the gold standard for viewing and imaging the anterior chamber angle, and it is more important these days. Just we discussed the previous case that we were not able to primarily diagnose the case. So gonioscopy is something which is very important for diagnosing the cause of glaucoma, as well as with the advent of MIGS. It is very important because we need to know the normal angle structure before dealing with them. So for a good gonioscopy, we'll need to answer a few questions. The angle structures that we are seeing, the type of iris configuration, the addresses, iridotrabecular contact, whether it is reversible, the extent of it, any past evidence of iridotrabecular contact, anything special like new vessels, any prominent iris processes, posterior embryotoxin, any evidence of trauma, or the patency of ostium or any new microimplants can be seen during gonioscopy. So the most important step is what is the posterior most structure that we are seeing while doing a gonioscopy. So this is a gonio photograph showing the angle structure. Starts from the shoulder line, non-pigmented trabecular meshwork, pigmented trabecular meshwork, a scleral spur and a ciliary body band, followed by iris root. The two most consistent landmarks that we have while doing gonioscopy are the shoulder line and the scleral spur. The first image is the corneal wedge method, which is used to identify the shoulder line. The two images from the anterior and the posterior surfaces of the cornea are used to form a wedge, and the termination or the meeting point of the two lines form a wedge which show the termination of descemet membrane represented by the shoulder line. And the second is the scleral spur, because scleral spur is something, when we see the scleral spur, we are very sure that the posterior pigmented trabecular meshwork and the Schlemm canal underlying it are visible. So this scleral spur is found between the pigmented trabecular meshwork and the ciliary body band. So if the scleral spur is visible, we grade the angle as open, and if it is not visible, we do indentation gonioscopy. Now, by doing indentation gonioscopy, if we find any shinical closure, we diagnose it as primary angle closure, and if it is not there, we see whether the IOP is raised or not. If IOP is raised, we label it as primary angle closure, and if it not, it is said to be a primary angle closure suspect or an occludable angle. Now these are two gonio photographs showing open angle images. In the first and the second, we are able to see the scleral spur, and hence we label them as open angle. Angle closure spectrum is a large spectrum starting from the occludable angle till the complete angle closure. Now this is an image of occludable angle. We can see the dipping of the beams. Occludable angle has been described as when the posterior pigmented trabecular meshwork is not visible in at least two quadrants in the primary position and without manipulation. So in both the images, in the primary position, we are not able to see even the shoulder line, so it is an occludable angle. Primary angle closure disease can vary from, in all these gonio photographs, these are of primary angle closure disease. In the first photograph, we can first see the goniosynechia or the path being formed, and the scleral spur is visible on the either side. In the second and the third photographs, it is a complete closure of the angle. Now we have to identify the extent of any iridotrabecular contact in the form of peripheral anterior synechia. These are few gonio photographs which can show the formation of pars in the superior and the inferior images. Now we have to see in case there are no peripheral anterior synechiae, we have to see whether there are previous iridotrabecular contact. What we saw in Dr. Shilpi's cases, there were patchy pigmentation throughout, and there were evidence that there have been previous iridotrabecular contact suggestive of subacute attacks maybe. These can be seen as coarse pigment clumps or pseudotrabecular meshwork. Whenever the trabecular meshwork comes anteriorly, it deposits some pigments even anterior to the Schwalbe line, forming a pseudotrabecular meshwork. And the crux here, in these two gonio photographs, we can see patchy pigmentation as well as a pseudotrabecular meshwork anterior to the Schwalbe's line. So the rule here is to form corneal wedge, and you have to see the apex of the wedge. Whether the pigmentation is anterior to the wedge, then it is a pseudotrabecular meshwork because of subacute attacks, and we are actually dealing with a closed angle. Then we have to see whether the iridotrabecular contact is reversible or not. That means, is it an oppositional closure or a synechial closure? What we saw in the last case was probably an oppositional or a synechial closure, which was going, which were very early, and probably they broke with the indentation or maybe so. So these are some gonio photographs. The first photograph shows oppositional closure, which opens on manipulation. Second and third also show oppositional closure, which is opening on manipulation. The last image shows a complete closure of the angle, where the angle doesn't open even upon manipulation or indentation. Now, peripheral anterior synechiae can even be seen in secondary angle closure glaucoma, such as uveitic and neovascular. These are some gonio photographs showing uveitic glaucoma. There can be patchy pigmentation, pigment clumps, very fine gonio synechiae or broad-based synechiae as shown in the second last image. And the pigmentation will be very uneven here and there, especially more in the inferior angle. Then comes the prominent iris processes, which are a physiological variation. They are fine lacy network of thread-like structures which are seen in the angle. They arise from the iris and fix somewhere near the scleral spur or maybe trabecular meshwork, or sometimes even up to the Schwalbe's line. These are just physiological variations and can be seen in geometry, myopia, as well as open angles. Anterior segment dysgenesis can be seen. The first image shows a prominent Schwalbe's line, which is also known as posterior iridotoxin, which is seen in Axenfeld rigor and other anterior segment dysgenesis. The second image shows iridocorneal adhesions. That is, the fine network of adhesions are arising from the iris and coming and sticking to the Schwalbe's line. Post-traumatic angle changes should always be considered in patients presenting with glaucoma, unilateral glaucoma, especially young patients who even deny trauma. There are a spectrum of changes in angle due to trauma, which can start from the presence of fibrin, clot, or a membrane in the angle recession, cyclodialysis, iridodialysis, trabecular meshwork tear, etc. Now the first image shows a widened ciliary body band. The second also shows angle recession, widened ciliary body band. Whenever we are diagnosing angle recession, it is very important to compare it with the other eye and different quadrants of the same eye to identify it as angle recession or a normal ciliary body band. The third image shows angle recession as well as cyclodialysis associated with it. The fourth image shows iridodialysis and cyclodialysis. Post-vitrectomy angle changes can be seen in the form of emulsified silicone oil or silicone oil bubbles. Post-glaucoma surgery changes can be seen. In the first image, there is an ostium which is patent. In the second image, there is an ostium which is plugged by the iris. And just to complete the list, pseudoexfoliation and pigment dispersion syndrome, both of them can have a Samper-Lacey line, which is pigmentation anterior to the Schwalbe's line. First image is of pseudoexfoliation, where the pigmentation, the increased pigmentation over trabecular meshwork is patchy, uneven, described as a salt and pepper pigmentation, and along with it we can have pseudoexfoliative material.
The second image shows the pigmentation of pigment dispersion syndrome, which is classically described as a masculine pigmentation, a thick even pigmentation. So this is just to complete my list. Thank you.
Thank you so much, ma'am. I think this was the complete atlas presented by Ritika ma'am on gonioscopy. So I think it will be very helpful for all the people. And I'd like to invite Meena Menon ma'am and Dr. Ajit Dwivedi sir will tell about the
So, Dr. Meena Gopinath Menon, I think she has a wonderful, she done her FRCS in 2001 after MBBS from Jawaharlal Nehru Pondicherry and MS Ophthalmology from Arvind Eye Hospital and DNB in 2001 itself. And she was a consultant as a medical officer in Arvind Eye Hospital, Madurai. From 2000 to 2002. Thereafter, from 2007 onwards, she consulted from at Centra Eye Hospital, Bangalore, and now at Coimbatore as well. And she has lot of publications. We have a long list, and important one to say in European Glaucoma Society, APAO, and many times in AIC, GSI, we always see a lot of the contribution from ma'am. And one thing which I would like to mention is a micropulse laser transcerebral cyclophotography. She has a study on that one, and we are just thinking of starting it here. And at the same time, so we are really pleasure and privileged to have you. Here are many chapters on our books as well, books in many chapters in many books, and many selected invited lectures and talk. So we are really privileged to have you, ma'am. Please welcome.
Thank you, Dr. Ajit. Thank you for giving me this opportunity to talk to you all, and probably we'll have a wonderful interactive session and a hands-on wet lab session also. So I am also kind of a newbie to this mixed technology. But it's an ever-learning process. The second talk again with the glaucoma drainage implants, newer and newer implants are coming up, and we adapt to the newer surgical technologies also. So let's go to the talk itself. So today we are going to talk about the mix that is minimally invasive glaucoma surgery using Kahoot dual blade. Thank you for the New World Medical providing me with some of the slides which I am going to use here. So this has a slide changer also. Yes. No? So as you all know, the conventional outflow pathway is via the trabecular meshwork. So usually the trabecular meshwork is one of the pathways where the aqueous humor flows through the trabecular meshwork to the Schlemm's canal. So that is a usual pathway which we have. Now who coined this term? All of you must be very familiar with Dr. Aik Ahmed. In 2009, he coined the name minimally invasive glaucoma surgery. Now what is it? So basically in minimal invasive glaucoma surgery, it's an ab internal approach. That means you are not touching the conjunctiva, you are sparing the conjunctiva. So it's almost atraumatic surgery, and most of the time it's got a very good sustained efficacy if your case selection is good, and very good safety profile. We will be going through some of the success stories of this using KDB. Very high safety profile and a very rapid recovery, and definitely the patient gets back to work within no time. So usually 1 or 2 days itself they can go back for their routine work. Now when we talk about mix, there is a lot of array of things, instruments which are being used. So when it comes to increasing the trabecular outflow, there are different methods. You have iStent, GAG, trabectome, hydrous microstent, and Kahoot dual blade comes in that. So it is basically increasing the trabecular outflow. So when it comes to increasing subconjunctival outflow, you have Zen glaucoma implant and Brazil flow. Now, what is the difference? Many of us must be doing goniotomy in congenital glaucoma. So, how do you differentiate what is traditional versus this excisional goniotomy? So, in traditional goniotomy, usually we perform it for congenital glaucoma. Now, excisional can be used for congenital glaucoma as well. Pediatric and adult glaucoma also it has been used. Now, in traditional glaucoma or goniotomy, we don't really will be able to lift the trabecular meshwork. Whereas when we use a Kahoot dual plate, we can elevate and then excise the trabecular meshwork to access the collector channels below. Now, when we do a traditional goniotomy, it is always an incisional goniotomy. That means you are using either a needle or you can use a retina people का क्या बोलते हैं उसको MVR blade, sorry, MVR blade to do the incisional or a traditional goniotomy. Whereas in excisional we use the Kahoot dual blade. We'll come to how a Kahoot dual blade. So he is Dr. Malik Kahoot, professor who invented this Kahoot dual blade. So the current one what we are practicing, basically why it is dual, it has got two blades, two sides. So if you see here, okay, so you can see here, these are the dual blades. This is called as a ramp. This is the tip of the equipment and this is the key. So when we are doing the wet lab, you will know that so that the tip, this part, it pierces. This is the trabecular meshwork and this tip pierces the trabecular meshwork. Next what happens, the ramp part, it lifts the trabecular meshwork. And then what you do, the dual blade, both sides of the blade, it excises the trabecular meshwork. That's how it works. So basically, moving. So as I mentioned, it easily penetrates the trabecular meshwork. So what are the advantages or benefits of excisional goniotomy? So basically it excises a strip of trabecular meshwork and it is implanted. There is nothing we are going to inject inside, and it can be performed as a standalone or along with the cataract surgery. Now what are the pre-operative considerations we have to do? Who all are good candidates? Now this is becoming broader and broader. So a good cooperative patient who will benefit from the enhanced flow of aqueous. There should be a good view of gonioscopy. This is very, very mandatory. Then only we can strip the nasal trabecular meshwork and with a good clear anatomy. Now any stage of glaucoma, nowadays that is what I mentioned, the indications are widening. Why I rounded the early part is, for a beginner, it is better to start with an early glaucoma rather than trying it out in a very advanced glaucoma. So early to severe glaucoma also can be done, and usually again when we start it's better to do in an open angle glaucoma, but as you become proficient you can do a goniosinolysis and then go ahead with the excisional goniotomy as well. Now, where should you not do? You should not touch in any patient with active neovascular glaucoma, uveitic glaucoma. When there is an elevated episcleral venous pressure, this is a little questionable. There are times people have attempted, there are certain anecdotal reports in the literature wherein they have attempted elevated episcleral venous pressure also. Poor view of angle, definitely no. There is no point. You are just trying to excise something. Ultimately, you might make a very deep cyclodialysis cleft, which can end up in a misery for the patient. So, poor view of angle, never touch. And if it is a very advanced glaucoma and where you want the IOP to be very, very less, probably this may not be a right choice of the surgery. Now what all you have to do, usual thing, you can either do as I mentioned standalone or as a combined with a cataract extraction. So basically if you are standalone, use pilocarpine before the surgery itself, and of course if you are doing along with cataract surgery, post cataract surgery, some people use pilocarpine, or even without you can continue with goniotomy. Now, what all you should do before you start attempting on your first patient? Make sure that you evaluate the angle and the anterior chamber very carefully in the clinic itself. Do multiple times goniotomy, understand your nasal angle very well. Then only try to start the thing. Again, how do you enhance the visualization? This is the most important part of doing a Kapoor dual plate intraoperative gonioscopy. So practice the positioning of the microscope and the motion of ab interno procedure before we do the first case. So he is not trying to do the case, it is just a manipulation of instruments and positioning of the patient, which is shown here. So this is the way you should try to do an intraoperative gonioscopy. We have to start microscope positioning. You have to move the microscope 30 to 40 degrees away from the vertical. If you see that, I will show you in another picture also. And then you lift up the, so if you see here, this is in my OT, wherein we have tilted the patient's head. You can see this is the patient's head, which is tilted away from the surgeon. So even if you see an adult patient, this is a pediatric patient after the GA, we have, it's under GA. So when it comes to an adult patient, you always say that the nose should touch. That much you should ask the patient to tilt the head, and then you have to tilt the microscope. Now when you tilt the microscope, you can see this is the tilting of the microscope, and the eyepiece has to be lifted. So that is, this positioning is important. This is an app which they have taught us, which is called as angle meter app in an Android phone. So you can see and then tilt the microscope. So this is the fellow measuring. Once you measure and understand a comfortable position, you can always mark in the microscope. You can keep a mark so that every time you don't need to do this. But this is the way it can be measured. Around 30 to 40 degrees is good tilt of the microscope. So this is something which you have to learn before doing your gonioscopy. Now, as I mentioned, it's the same thing. So you have to view the angle. Now, this angle viewing is called as en-face view. So it is not that we are trying to see it steeply. You have to see it in en-face. So that is called as en-face view, which is important in intraoperative gonioscopy. Next important part is what are you seeing? What are the structures which you are seeing? When you do an intraoperative gonioscopy, you should make sure that you are able to understand all the structures what you do see in a routine gonioscopy. So that is the third point, what you are seeing during an intraoperative gonioscopy. So when it comes to an intraoperative gonioscopy, these are the typical 5 tips which I tell. Patient position is important, microscope tilt, how you hold the lens. Now no too much pressure, no too lesser pressure. That is also important. Too much pressure can cause corneal folds and can obscure your vision. So no too much pressure or too lesser pressure, and as I mentioned, know what a good view is. Then now that good view is an en-face view, which is during the intraoperative gonioscopy. And of course, we should understand the anatomical structures what are seen during the gonioscopy. Now, so these are the instruments which we use during gonioscopy. You should have a high viscosity viscoelastic. This is a Swanstick of Godio lens. This is a Katina lens. Both the lens we use during gonioscopy, intraoperative, and this is a Kapoor dual plate, and this is a intraocular scissors, micro scissors, so that you can remove the trabecular mesh was remnant. Now, what are the techniques which you can follow? So there are 3 different techniques. This is taken from the company video. So these are different techniques called as outside in or inside out, wherein or mark and wheel. So outside in is basically from outer to the center. If you see here, and from again you go from the other side outer to in. So this is called as outside in technique. So you can follow any of the techniques. I don't think there is any comparative study between these different kind of a techniques. It's more of a surgeon's comfort how you want to handle. This is the inside technique. I personally follow the inside out technique, which is a quite easy technique, and I think most of our maneuvers are always inside out. So that way inside out is always very convenient. And then there is the technique called as mark and meet. So you can mark and then you can join that points. So you can see there are 2 marks which is kept, and then from that, from here to here to mark, make the meet the mark. So this is a video wherein this is after the cataract surgery. So again, a good amount of viscoelastic has to be injected into the AC, and this is, I am using a Catena lens. If you can see, the Catena lens advantage is that there is a tip at the edge, wherein near the section you can put the Catena lens, and once you get a view of the angle, then you can use the Kahoot dual blade, and like as I mentioned, like this is called as inside out technique, which most of us follow. So whatever area which you think which is not done, you can always go back and do it. It's like kind of repeatable repeatable procedure. So what all you should know, one important thing is flared clear corneal incision. Now suppose you are doing as a standalone procedure. Now I prefer to put a 2.2 incision even if it is standalone, because you have to maneuver the instrument through the incision. So you try to put with the side port, your maneuvering becomes a little challenging. So you know your 2.2 incision for a cataract surgery is good. It's a valid incision, so it gets closed. So you don't have to worry. Be liberal about 2.2 incision. But one important thing is don't put limbal. Like go real clear corneal, because that limbal bleeding can really be irritating. It can obscure your vision. So make sure that you are more clear corneal than when compared to cataract surgery. So many a time cataract, you try to be a little limbal so that your vascularization and the healing is better. But in this procedure, it is better to avoid that. So that is very important, and some people advocate a little flare inside. I am not a great fan of that flared part, but still the instrument maneuver is slightly better with a flared incision. So another important thing is always make sure that the foot pedal is seated well in the canal, and another thing is you should try to put the blade onto the trabecular meshwork. If you are too superficial, you are only using a tip, because the whole dual blade is manufactured like that. The blade is the one which should be cutting, not the tip. So your tip is only to enter, your pointed tip is entering, and then the blade is trying to excise the thing. So it should make sure that we are not too superficial in the trabecular meshwork. Another important part is dispersive OVD can maintain an excellent view when you expand the angle, because inject nicely into the angle so that your angle view is very good. And we can leave a little bit of OVD in the anterior chamber, because post-operatively you can have some blood reflex, but nothing to worry about it. That kind of gets washed off, or the next day you don't even see the hyphema. So what do you do if you have a reflux? Nothing to worry. So when you have a reflux, it is bound to happen. Basically, it is a blood from the Schlemm's canal which you are going to see. So one way, if you see the blood, it is good that you are in the right track. But if you see the blood, then don't try to do it in the same place, or stop and then see, you can displace nicely with the viscoelastic. So you can displace nicely with the viscoelastic and then proceed with the procedure. So avoid doing when blood is there in your angle because your vision is getting obscured. So at the end again you can put a little bit of visco and keep it so that the tamponade is there and it encourages the flow of the fluid also. So other additional pearls if you ask me, so if you see here, there is an air bubble which is there under the lens. So this is something which you should avoid. Use copious amount of viscoelastic, you can put it over the lens also, so that also helps, and on the cornea. So if you get an air bubble like this, remove it, do it again, put lot of visco and then try to visualize. Another thing is, if you see here, I am not even seeing the angle structures because I am giving too much of a pressure. You can see these folds, I don't know how visible it is. So these folds indicate that you have pressed the angle, you have pressed the lens too much. So make sure that your pressure with your left hand is very minimal. Now if you are too superficial also you will not see. If you are dipping too much also you will end up getting pressure. So this is one of the important part which we should always remember. So that is why do lot of intraoperative gonioscopy in normal patients. Just try doing the gonioscopy before you attempt your first patient. Now another thing which is very common, I didn't have my own picture of stain, that's why I have not put. You can see beautifully these collector channels stained with blue when you inject this trypan blue inside the AC. So that is probably more than KDP. You see in eye stent, you know that the stent is working, that you put a trypan blue, you will see beautiful collector channels getting stained. So what are the post-operative considerations, routine post-operative considerations if you are doing it with cataract? Your routine protocol, what you are going to follow. You can use an antibiotic steroid combinations you can use, and generally better avoid stopping the anti-glaucoma medications the very next day, because many of these patients can be a steroid responder. So you can continue your anti-glaucoma medications till you are convinced that it is, the pressures are come down, and slowly probably you can remove it. Now the use of pilocarpine, many of the surgeons we use pilocarpine at least for 4 weeks. So to avoid any kind of adhesions. So 2 or 3 times of pilocarpine can be used. Again, there is a controversy about using a pilocarpine, especially when you are doing along with cataract surgery. Pilocarpine can increase a little bit of inflammation, but you are pumping in steroid. So it is like plus minus, that's why we put as a coagulant pilocarpine. But it does help you in the post-operative period. So again, as I mentioned, IOP lowering medications, you generally may not stop immediately. Go through the patient, because steroid responsiveness is something which you need to understand, especially glaucoma patients, they are steroid responders. So just to go through some of the success stories which have been published. So this is a very long-term study which is published from Mayo Clinic and multicentric thing. Clinical outcomes with Kahoot dual blade. So they found that it effectively lowered the IOP almost by 28% from the baseline, and definitely reduced the burden of glaucoma medication. Basically 46 to 47% had surgical success as defined by success criteria in this study group, as more than 20% reduction, and no surgical intervention, and the IOP was maintained between 4 and 21. So this is a retrospective study of almost 90 eyes. So it's one of the longest duration of study which is available in the literature right now. And this is again with and without phacoemulsifier. Here the number of patients they have reviewed is huge. It's around 197 eyes they have found, and this study was done for almost a year. They had both groups standalone as well as along with the cataract surgery. So they also found that mean IOP was significantly reduced to almost 16 to almost 13.8, and there was medications reduction as well in both the groups, phaco KDP as well as the KDP group. Now this is an Indian study from the LPP group, wherein they have published it as a 6 months outcome. It is a little less eyes, but we can always extrapolate because being an Indian eyes. So definitely they found that phaco with KDB goniotomy, it helped to lower the need for AGM and good reduction of IOP even in advanced open angle glaucoma, and they didn't find any kind of a major complications and the visual recovery was always good and early visual recovery. So if you ask me, the main complications post goniotomy is very minimal. One of the common complication you can see is hyphema, which definitely clears up in no time. So I don't think we should be worried about the complication. The spectrum of complications is extremely less. It's a very safe procedure. So to summarize, like basically you remove the tissue, excision and removal of the tissue. It's an implant free, you're not injecting anything, and it can be performed as a standalone or as a combined surgery with cataract excision. Thank you so much.
Thank you, ma'am. There is interactive session on MIS itself, so we will continue for the next one. One question only.
Sure.
So to which extent you excite?
So it kind of covers almost, I can say 130, 140. Like, if you see nasal angle, almost that much, like a congenital glaucoma goniotomy. I will not say 180, maybe 140 to 150 we can easily cover it.
That's with a 2.2 incision.
I would, like if it's a standalone,
yes.
Of course, if you are doing with cataract and whatever you are doing, 2.2 or 2.8, whatever you are using as a routine practice, you can use that.
Sure. MIS is upcoming surgery, I think very well taken by the benign glaucoma surgeon.
Yeah.
And definitely the new, the advanced glaucoma, we need these implants. So importance of this cannot be denied. So please.
Yeah. Definitely, this spectrum is still there. The patients are there in this spectrum also. So the glaucoma.
One more question, ma'am.
Sure.
Regarding the post-op AGM, which AGM you will prefer to stop? I have option of reducing the aqueous formation, or increasing the tubercular outflow or uvuscular outflow.
So if you ask me, if at all you want to stop, you can stop a prostaglandin analog, because considering if you are doing it as a combined cataract. But then right now, last few years, there have been umpteen number of literature wherein shows prostaglandin analog will not cause CME if it is an uneventful surgery, or if you are doing it in a non-diabetic or even diabetics who don't have any diabetic retinopathy changes. So if you ask me, personally, I don't stop any medications till I am convinced that things are becoming better, then I stop. So if that option of stopping, probably if you see mechanism wise, definitely see aqueous reduction drops. There is always controversy when the glaucoma specialists discuss, even after TRAP, whether some people say you give a beta blocker, some people say don't give. Again, I don't give anything. After my TRAP, I stop everything the next day on. But KDB probably we still have to see, because we are almost dealing most of the time early to moderate. And even if it is severe, we will not stop immediately, because all these patients are steroid responders. So the choice remains with you. Mechanically, like okay, because you are increasing the outflow, already you have increasing the outflow after doing an excision, so you may not really need to decrease the outflow. So personally, I will not stop the next day. I will wait and watch how the tide over that steroid response. Because see, if you are doing it standalone, as I mentioned, the hyphema and all is not great. So you don't have to really pump in so much of steroids. So you can even use the soft steroids and taper it. By then you will know how your eye pressure is also, and then you can always stop it.
So in a standalone procedure, you can stop it after 2 weeks or so. The steroids.
It depends. Yeah, that's what. It depends on how
the patient is
responding. Yeah.
But actually, according to majority of your patients, you stop it by 2 weeks or 3 weeks.
2-3 weeks, maximum 1 month. They don't come in back 2 weeks sometimes. So 1 month is a good window period for you to understand how things are working. Now for me, I'm sorry I kind of missed out on today. I've been trying to understand, because there's a very beautiful study which is being done about the structural variation It is a comparative study of a structural variation of using an ASOCT or ASOCT with a Kahoot dual plate, and which is compared with something called Tanito microphone. Tanito is a person from Japan. He's a glaucoma specialist from Japan. He has, kind of invented something called Tanito microphone. Currently, it's not available in India. So they've done a beautiful analysis structurally. Now, I'm also trying to understand structurally what really happens in Kahoot dual plate. Now, we talk about excisional. Are we really excising? So we are trying to do an ASOCT. So sometimes from the ASOCT, I do gonio for all my patients once they come back, because I need to understand whether are they having inflammation, are they getting into some kind of a PAS, which is very rare, but this is more of a learning thing because all of us are learning. So, what really structurally happens. See, most of the studies will be based on IOP and things like that. Structurally, this is a very beautiful study where they have done a comparative ASOCT structural analysis. So, we also try to understand structurally, are we doing the right thing by doing, if the facility for ASOCT is there, nothing like it, you can really understand how it is behaving. So, sometimes that also helps me. If I am seeing some kind of a remnant I have left over, I am little worried, will that become a PAS? So then let me just go slow. One by one you can stop. Again, like stopping, suppose the patient is on 3-4 drugs and then you have done a KDP. Like one of my standalone is a strong family history, she is only 28-year-old. I didn't want to touch the conjunctiva. Mother I have operated, sister I have operated, brother is already on anti-glaucoma who is just 20 years. And she started coming to me at 19 years when the mother was diagnosed. Her pressures are just going up. Now what is the reason? It's just an open angle or juvenile open angle. Now here I definitely don't want to do a trap. I don't want to touch the conjunctiva. In such patient, I am not going to stop all 3 drugs all of a sudden because she's got a major family history. So you never know. So I have not stopped her, but I have stopped one of the drug. Like one by one, you can see and then stop.
So the tapering starts after 4 weeks maybe?
Yeah.
And any particular order in which you...
Nothing like that. Nothing like that.
Glaucoma is a dynamic disease, I think, throughout life.
Two queries I have. Like for a standalone case, instead of using a steroid, non-steroid anti-inflammatory, can it work on it? Because steroid is that can be taken care of.
Yeah. That's what I said.
Yeah. So that can be tried.
That can be tried. Soft steroids, you can try anything.
Which is the company which is providing this Kahoot plate in India? Any Indian company? And what is the price? So you are there. I'll just get back to you.
Yeah.
Just for the query, what is the price of the Kahoot? 30,000.
So moving forward, I think we can come on that glaucoma drainage implants, and this live interaction will go on from 48 itself.
Sure. So this is the other spectrum we are going to talk. The intractable glaucomas. So it go back in 1907 when it started these implants and cetons and all that. So we have come a long way. 1993 Ahmed introduced AGV, and then 2013 we came with the Norolab aqueous drainage RO made in India, and then 2019 Ahmed Clear Path was introduced. Now what are glaucoma drainage devices? So basically they create an alternate aqueous pathway from the anterior chamber, or rather from the posterior chamber to the subconjunctival flap or the suprachoroidal space by channeling the aqueous out through the tube. Now there are different types of drainage devices which we call it as cetons, stent and valved and non-valved implants. We will be talking about the valved and non-valved implants. Now stents, many things are coming up, more and more stents are coming up. When we talk about the implant, we talk about the type of the plate, material and the type of the opening. Now there are again rigid and flexible plates which are available, and the common materials which are used are silicon and polypropylene and hydroxyapatite materials. When it comes to the type of opening, again we have something called valved and non-valved. So if you see non-valve, you have the Ahmed clear path. These are the two Ahmed clear path which is available, which is 250 and 350 millimeter square. And then you have the bare weld, RD, and these are all non-valved implants. And the valve you have Krupin, and what we use is Ahmed glaucoma valve. So what is the pathophysiology behind this drainage implants? Basically a fibrous capsule is formed over the end plate within few weeks of implanting putting the implant, and aqueous humor it holds in the potential space between the implant and the surrounding fibrous capsule. Then the aqueous passes through these capsule by the process of diffusion and is absorbed by the periocular capillaries and lymphatics, and the fibrous capsule around the plate, it offers a major resistance to the aqueous flow with the drainage implant. Now what are the indications? You have all previously failed glaucoma surgeries, all the secondary glaucomas, neovascular, uveitic, and any kind of previous intraocular, post-VKPIs, post-TKPIs, post-DSEC eyes. Now the cornea people are doing more and more procedures. Post-traumatic, sometimes congenital or juvenile glaucoma when they are associated with anterior segment dysgenesis, aniridia, all these things, it can be used as a primary implant. Glaucoma in phakia and pseudophakia, and as I mentioned, PKP, post-PKP, and of course other secondary glaucomas like corneal endothelial syndromes. And contraindications, definitely no in malignant glaucoma, but I will still put it as a relative contraindications. Day before only I am done for a chronic malignant glaucoma. Acute malignant glaucoma, avoid. But chronic malignant glaucoma, so many of you might be knowing, it's a newer entity which is coming up, something called chronic malignant glaucoma. You still can use implant actually. With caution, when there is a lot of fibrosis of conjunctiva, wherein your suturing can be a challenge. There are multiple retinal surgeries have been done. When there is a buccal or a tube, I ask them to either remove the buccal or the encirclage, because you need sometimes space. So that way probably a clear path is a boon because it requires a very less space. Now when you post a patient for an implant surgery, please look at the mobility of the conjunctiva in your clinic itself. So use a bud, put paracaine into the patient's eyes, understand the mobility of the conjunctiva, which quadrant you want to operate. So many a time these patients would have undergone multiple surgeries. Now you don't know how the conjunctiva is. So the ideal area quadrant will be a superior temporal, but many a time because of various reasons you may have to do it in other quadrants. So understand the mobility of the conjunctiva. Any kind of thinned areas of sclera should be avoided. How the corneal endothelium is, because if you are going to put the tube in the anterior chamber, is the endothelium healthy? And again, iris should be identified for any kind of a new blood vessels. Depth of the anterior chamber becomes important. Are you going to put in the anterior chamber, or you are going to put in the sulcus, or you are going to put in the posterior chamber? Lens status, and of course you have to do gonioscopy to understand whether there is any peripheral anterior segment. So he is Dr. Ahmed who designed this Ahmed glaucoma valve, which has got a plate, which has got there is a plate which is there, and then there is this valve which is there, which is again made up of a silicon material. So the basically it's more for a PG's Bernoulli's equation is followed in the mechanism of the AGV valve. And these are the different types of models which are available. What we generally use is FP7 and FP8. FP8 is mainly for pediatric. Doesn't mean that you use only for pediatric. Adult cases also, in case your space is a compromise, you can use an FP8. And then you have this PC7 and PC8 which can be put in pars plana, but most of us use the same FP7 and FP8 for even for the pars plana implantation. So this is again the two models which are there, as I mentioned, FP7 and the FP8 valves. So this is a, so you measure it around. So nowadays I am doing it as a lingual based flap. So this is a priming of the valve which we do, and then once you make the conjunctival, adequate conjunctival incision around 7 to 8 millimeter. You anchor the plate onto the sclera. You use a 9-0 nylon to anchor the plate. There are various methods wherein you can anchor the plate. You can use it through the eyelets, that is the most commonly used method, and then you have to anchor the tube also onto the sclera. Otherwise the undue movement of the tube can result in an erosion. Then you have to adequately cut. I don't do as a patchless because I have got readily available sclera, so I generally don't do much of patchless. Now this is a patient of NBG. Now I have put it into the anterior chamber. So this is called as a little bit of sinusoidal, if you see that sinusoidal angling of the tube wherein we do that. So again the movement of the tube is little restricted when you do a sinusoidal. No, it's there. I think, so after that we use a scleral patch graft to cover the tube, and then the conjunctiva is covered. Here I use a continuous 8-0 vicryl suture for covering the conjunctiva. So this is a basic surgical steps which we do, and so regarding the tube placement, you can do it in anterior chamber or in the posterior chamber. When do you do in posterior chamber? Most of the secondary glaucomas when there is an extensive PAS, and any secondary glaucoma where there is a compromise of corneal endothelium, then it is better to place it in the posterior chamber. And PKP eyes, many a time the corneal surgeons will ask us to put in the posterior chamber. Again, you have to do a core vitrectomy before putting it in the posterior chamber. That is very important. Without that you cannot do the surgery. So this is a patient wherein we have done a posterior placement. This is a TKP done twice and a secondary glaucoma which is done. So this patient usually either you can use a 23 gauge, 24 gauge needle entry itself, or you can use a port itself, you can enter with that. So this is the vitrectomy being done by my retina colleagues, and once it is done, you can use the same port site to place your tube. So you don't have to make multiple entries, the same port site, because nowadays all of them do a 23 gauge vitrectomy. So in the same where they had entered, I trim the tube and then put it into the pars plana. So vitrectomy is very, very important, otherwise you can have a tube being blocked by the vitreous. Now in this situation you can even put it in either pars plana or you can put it in ciliary sulcus also. So many of the post PKP we put it in ciliary sulcus as well. So when we talk about Ahmed clear path, so this is basically a non-valved implant. Now if you see, it comes with a 23 gauge needle, and this is a very unique design. So this is 350 and 250, you get both millimeter sizes. You will currently, I don't know whether it is both are available in India, but right now they've started with both. I use more of a 250. So 250 is a true single quadrant device. So the basic advantage is it's a very, very easy surgical procedure. You don't have to isolate muscles, unlike say a Barwell or the currently Indian available RD. So you don't have to isolate the muscle at all. Plate is pretty low lying, and as you saw, the you can easily inject. You can easily implant it in patients who have a very tight orbits, or even in pediatric patients. So yesterday when I was discussing with somebody, I have done almost all my ACPs in pediatric patients. So it is very easy because it's a very small device. It's a very, very small device, and again the anterior positioning of eyelids help the suturing very, very easily. So this is an ACP. This, if you see, it is a patient with aniridia. So already once trap was done. This is the failed trap which you can see. So this comes with already an existing 40 proline ripcord. Now this is an important step if you see. So this is called as taco technique, wherein you fold the implant and then you place it inside. So that much conjunctiva only you need to cut. So that is called as a taco technique, and again you have these eyelets where you can anchor it to the sclera with a 90 nylon. You can see the ripcord suture which is there. Now this is a small technique which I learnt from my colleague Dr. Sirisha of LVP, wherein the ripcord end is put in a small tunnel so that it doesn't kind of come out through the conjunctiva. So you can, when if you want to remove it later date, you can just put a nick beyond that tunnel, and then it just easily comes out. So one of the pediatric, so this is a stenting slits which you do in these non-valved devices. You can use either your 90 nylon needle itself to put the stenting slit. Stenting slits has to be put above, that is beyond your ligation suture. So the ligation suture you can either use a 7-0 vicryl or a 6-0 vicryl for the ligation. So this is the steps which are slightly different, but there is no isolation of muscle, only the ligation which you have to do it very correctly. So once we ligate, always cross check whether there is any flow of aqueous which is happening. So this is an aniridia, the lens is intact, so I have put it anterior to the lens, the tube. In pediatric, make sure that the tube is slightly of the longer length, because there can be a growth of the eyeball, as well as because of the plate and because of the fibrous capsule, there can be a retraction of the tube. So make it a little longer when you are doing in a pediatric, and after that you can cover it with the patch graft and the conjunctiva suture with the 80 vicryl continuous suture. So the advantage of doing this limbal based conjunctiva is easy to implant and suturing. So, but you have to be good in continuous suturing. That is something which we have to learn, and then it becomes easy. So these are some of the success stories with ACP. So this was a study which was done in 22, which was published in 22, wherein 104 eyes of 100 subjects they had used 250 or 350 ACP, either as a standalone or as a combination with cataract surgery. So what they found is, what we have to see here, standalone was the most common, because generally drainage implant standalone is more common, and most of the patient, like 100% you have to ligate the tube. The non-valve implant, 100% you have to ligate. Now if you see the ripcord used, around 68% they have used the ripcord. Now the ripcord suture may or may not be needed to be removed. Now in pediatric population they suggest that better avoid, because removal becomes a challenge. In adult patients you can always remove it in the slit lamp in the OPD. In pediatric patients it can be a challenge. Again you may have to give a GA to remove the ripcord suture. So the ripcord is almost 68%. Little bit of surgeon dependency is there. Ripcord, you have to understand how your cases are behaving and then probably decide on a ripcord. And tube fenestration also, almost all the patients they have done. Now if you see the ripcord removal, they have done a ripcord removal only in 3 eyes at 1 month, 3 months in 8 eyes, and at 6 months they have removed at 8 eyes. So a single intraoperative adverse event of aqueous misdirection was happened in this series, but most common adverse events were anterior chamber inflammation, hyphema, hypotonia can be a challenge rarely, cystoid macular edema, limbal wound leak and tube erosion, which is only a 3%, and PIC. So there was a good drop in intraocular pressure, almost 13.7 millimeter of mercury, and the medication used was reduced. This is a very small study, but it's a long-term study. So this again comes from Mayo Clinic. So 12 patients only they are studied, but it is for 36 months. So most of the patients were severe POEG patients. So most 83% of the patients had undergone a previous glaucoma procedure. Whatever may be the glaucoma procedure, they have undergone glaucoma procedure, and they didn't find any kind of vision threatening complication throughout the follow-up period of 36 months, and there was no evidence of any glaucoma resurgeries happening in any of these patients. Complications include buttonholing, we can have intraoperatively bleeding, the length and the position of the tube, scleral perforation and rarely expulsive hemorrhage because you might be attempting in a high pressured eye. Post-operatively, you can have hypotony. This is more common with an AGD than a non-valved patient. Hyphema, a wound leak, tube occlusion can happen, Delin because of the heaped up conjunctiva when you suture. So especially in a phonic space wherein you are near your limbus, there can be a heaped up conjunctiva. Malignant glaucoma, rare, but can happen, and something called hypertensive phase. Now post-operatively, when there is a poor flow control, you can have hypotony, shallow anterior chamber. Some situations, if you rule out choroidal effusion or other reasons, very rarely you may have to position the tube because one of the reasons can be a peritubal leak. So entry has to be with a 23 or 24 gauge needle, or even 25 is better, 24 and 25 because it's literally snugly fits the tube. So peritubal leak is something which can result in a chronic hypertony. When it comes to tube hitting the iris root, it can have hyphema because of the iris vessels. If you see here, this tube was touching the endothelium. This is a post-traumatic eye wherein my retina consultant, Dr. Mahesh, had done a vitrectomy, everything. It was a young kid, but I had initially placed the anterior chamber tube, but then unfortunately it started hitting the root of the iris and the corneal endothelium. So I had removed this tube and then did it to the past plan because already a vitrectomy was performed by the retinal surgeon, so it becomes much more easier. Now if you see here, this is a picture of an aniridia wherein we had removed the lens also, but the tube, you can see this marking. This is basically a vitreous which has gone and plugged. So what happened is in aniridia it becomes a unicameral chamber. So how much ever vitrectomy is that, there is still, because of the unicameral chamber, it comes and blocks. So again we had to go and do a little more vitrectomy to make sure that the tube blocking is avoided. So to prevent, basically cut always the tube vivella, look for any kind of a vitreous if you are doing it in an aphakic eye, and blocked, whether we can do even hit the vitrectomy with a yard cutter. But this patient, it was not enough using a yard cutter, so we had to go and do a vitrectomy again. Now Delin basically used for a lot of lubricating drops, and only thing is that Delin should not get infected. So these Delins are sometimes prone because you would have done it in NPG, so patient can be a chronic diabetic. So just make sure that the Delin is not infected. Now malignant glaucoma, usual management you should try if you are suspecting a malignant glaucoma. Hypertensive phase is a very common problem which you can face after using a glaucoma implant. So what is hypertensive phase? It is usually an intraocular pressure more than 21 within the first 3 to 6 post-operative months. Now slightly change the definition. When it comes to a valved implant, it is immediate hypotony. When it comes to non-valved implant, it is when the ligature gives way. That is, if you put a 6-0 or a 7-0 vicryl, so it will be somewhere around 6th or a 7th week. When the ligature gives off, that is a time when you can have hypotony, and post that you get this hypertensive phase. So in a valved implant, you will get it. You can have immediately also, or usually 2 to 3 weeks also it can start. So basically in hypertensive phase, it kind of gets over. You can introduce your anti-glaucoma medications when you suspect an hypertensive phase, and basically put in a little more steroids, make sure that there is no inflammation. Rarely we may have to do a phlegm division. Late post-operative, all kinds of exposure can happen. Tube, the plate can expose, encapsulated blood can happen, and strabismus is not uncommon, especially with the large implants. Strabismus is not uncommon, and endophthalmitis rare. Now tube exposure not an uncommon thing. So how to avoid this? Make sure that the tube tract is proper, and micro motion of the tube is always reduced by putting the metal suture. That is why I said you have to anchor the tube. Matlab, like the tube should be always onto the sclera. If the tube becomes little protruded, then it can cause tube exposure. Then you can give doxycycline if you suspect any kind of tube exposure. So this is one of our case which we have published in a journal, wherein we have used a skeletal patch graft and a double layered amniotic membrane also, and then over that conjunctival autograft. This is again a patient who had a tube exposure. This what we did was a patient, a high bio, who had a buccal encircling band. She has a very huge eye. Dr. Mahesh had left it as a FAK because it was that huge, there was no lens which was required. So this patient had a recurrent tube exposure just because she had a very huge eye. And AGV blebs are very pain. So because of this, then we had to use these patch graft, amniotic membrane and a conjunctival graft. So plate exposure, very difficult to manage. So this is again one of our case wherein there was a plate exposure. So what are the problems and why does it happen? In pediatrics, please make sure that child doesn't rub. So I have get away with one plate exposure with a pediatric kid by suturing the conjunctiva. It was okay, but one adult we had to explant because chronic diabetics, it is very common to have a plate exposure. This is a beautiful study. It's a 6 cases study from the LGB team, wherein they have found that almost all cases of plate exposure they had to remove. Now either you can remove, you have to remove, and then you may have to re-implant on different position, or sometimes you can just manage medically and see also. So plate exposure is a very difficult thing to manage. So tube retraction, as I mentioned, in pediatric population, you have to make a little more lengthy tube so that when the growing eyeball, it doesn't get retracted. Now this is a tube extender which is available with the same company. So you can use this tube extender and then redo the surgery. So this is rarely we have to do a needling encapsulation, bleb encapsulation, which can happen. Very thick fibrosis. So we just have to cut the conjunctiva, cut the capsule and come out. And again, there are studies wherein they have injected MMC onto the capsule because again they don't want the fibrosis to happen. So there are instances, especially in children, you can have bleb encapsulation. And dysesthesia, give a lot of lubricating drops, and strabismus, not too uncommon, very large GDGs. Now with the advent of Ahmed clear path, it has become smaller and smaller. So this problem will be even more rarer now. And of course, this is the last, I think I'll put the last slide, that is an endophthalmitis. This is a study which was published, the endophthalmitis in GDD, which is not very high. So basically why it happens is the moment you see a tube exposure, you have to manage it immediately. Tube exposure can be a forerunner for an endophthalmitis. This is a dreaded complication, definitely none of us want to have, but it can rarely happen. This is one of the studies which they have published with Ahmed glaucoma valve, the AGV, not the clear path. Clear path, no study has come out with any sort of infection. Thank you.
Thank you, ma'am, for your insight in both the spectrum of the glaucoma. And moving to the workshop, I would like to come forward, and I would like to come forward, Dr. Patna Ranjan sir, in felicitating our speakers, Dr. Silpi Kedia, certificates and memento and plan. Please come forward, ma'am. You will be the, I think it's a series to have a, we all are, please. Dr. Praveer, you can join. Dr. Bhavesh.
All the senior people, please join us in this.
Please join. So it was really publicity talk is always practical now. She brings out cases for all of us. Thank you.
Should be your favorite.
Dr. Ritika is from EMS and now she's very proficient IT and we have a wonderful seminar to be possible on a neovascular glaucoma research.
Oh, very nice.
And people work from all India and pictures of one case I have borrowed further from and this is from for Dr. Meena from and our guardian Mr. Glaucoma.
Academic के लिए मुझे nice है।
We can have a photograph.
Use it the Indian way.
I didn't want to say that I.
Dr. Ranjana Kumar is the treasurer of Bihar Ophthalogical Society and
तो पैसा दे देंगे सर कहूँ के लिए
acting nationally Women Ophthalmical Society.
Pleasure to be here, pleasure to learn more things from experts, and this is a great opportunity. Staying in Bihar and learning to do things without visiting anywhere for a special workshop. Thank you so much.
And now we are inviting for the workshop anybody who are in a group 1, I think. Ramesh Kumar is from Arvind himself. Transcendental Vedi Dr. Bhavesh is from Patna Ophthalogical. Lot of work on creating club. As a winner in the MTC.
ले जा